Good evening, good morning, good afternoon, everybody. My name is Mohamed Moti. I'm from the Sorbonne University in Saint-Antoine Hospital in France. It is actually 6 p.m. in Paris, 5 p.m. in London, and noon in Tampa and New York. It is our traditional ICH Journal Club. This is the Journal Club brought to you by the International Academy for Clinical Hematology. We do have a twice monthly journal club. The steering committee, the scientific steering committee, has chosen for this journal club today this recently published paper in the Journal of Clinical Oncology by Dr. Hansen and colleagues. And the title is, I will try to make it short, Idecabtagene for relapsed refractory multiple myeloma, real-world experience from the Myeloma CAR-T Consortium. And as it is nicely summarized in the title, actually, this was a sort of a retrospective collection of patients with relapsed refractory multiple myeloma who underwent leukapheresis and received actually the Idecabtagene CAR-T cell construct in 11 US institutions as part of a standard of care. As we all know, Idecabtagene has been approved based on the KARMA trial with 127 patients published in the New England Journal of Medicine in February 2021, if I remember well. Then later we had Cilta-cel approved also for relapsed refractory multiple myeloma. And here we have a sort of a real-world evidence about the use of Cilta-cel. And to make a long story short, actually, and that is interesting because the authors were able to analyze not only those patients who were infused, but also those patients who were leukapheresis but could not be infused. They have also very nice and comprehensive data about the safety profile, especially CRS and neurotoxicity. And here I have chosen these figures, these two panels, because in my opinion, they summarize the whole story where they could demonstrate roughly 84% overall response, best overall response in 159 patients. And when focusing at day 30 and day 90 responses, we have around 78 and 72% respectively. And another important finding from this relatively large cohort is the median PFS, which is around 8.5 months. And when we look to the conclusion of the editor who handled this paper at the DHCO, Dr. Susan Lynch from Columbia in New York, actually she wrote that the efficacy and safety profile of standard of care Idecabtagene is comparable with that observed in the KARMA trial, although most of the patients would not have met clinical trial eligibility criteria. And this is, I think, an important issue that we will discuss with our guests. And another important finding was that if BCMA CAR T-cell treatment is planned, a prior exposure to BCMA targeted therapy should be avoided. So I'll stop here, and I would like to welcome our two guests, two panelists today. First, Dr. Doris Hansen from Moffitt in Tampa, and she is the first author of this superb work. Congratulations, Doris.
Thank you.
And the other panelist, who is not a co-author, but who is also a leader in the CAR field, is Dr. Roni Shouval from the Memorial Sloan Kettering in New York. And as usual, you know, if I use my non-written SOP for the journal club of the IACH, first question is always to our guest, although I would always usually say ladies first, but here I'll go to Roni. And Roni, the question to you is to have your general feeling about these results when you saw this paper being published. And I know probably you are quite positive and enthusiastic about it because you are now leading the CAR T-cell newsletter of the IACH, and I think you have featured this article as the key finding of the February newsletter with a nice podcast from Doris. So what are your feelings? What are your take-home messages before I go back to Doris?
Thank you, Mohammed, and thank you, Dr. Hansen, for joining. So I was obviously very enthusiastic before when I saw this patient. At first, I just want to congratulate the authors for compiling such a large cohort, 11 U.S. centers. I mean, that's impressive, and the work and logistical work behind that is quite significant. Now, we could talk a lot about the clinical findings of the paper, but to me, this paper is first and foremost a testament to the importance of real-world data, in the sense that when you read the paper, and I had to read it twice to really believe it, 75% of the patients in this analysis were actually ineligible for participation in the KarMMa clinical trial. And this is the same clinical indication. The reasons for exclusion or ineligibility of these patients were mainly because of comorbidities at the time of leukapheresis, some cytopenias as well. And the fact that we now have a go-to paper that can actually show us that Idecabtagene is safe in this population, I mean, in patients that are more frail and comorbid, really serves the community. And we just discussed that before starting the interview. So I really want to thank you for that. Other than that, I think the fact that this paper managed to reproduce the finding from the pivotal clinical trial really speaks to the quality of the first trial and the design. And I think it will help us guide the field forward and really useful tools for us as clinicians and for us to guide decision making.
No, thank you very much, Roni. And I'm glad you are highlighting the value of real world evidence, and they are usually quite difficult to capture. So here, Doris, I'd like to hear from you more about the idea of having this registry or this series or cohort. I don't know exactly how you managed to get these 11 institutions working together to get this lovely series, and with such a level of details, because usually when we speak about real world data or evidence or registry, one of the criticism is about the quality of the data. And here I believe, and I read like Roni this paper several times because I usually prepare quite comprehend in a thorough manner the journal clubs, trying to find all the details. It looks like that you manage really to dig deeper into these patients, looking into each individual parameter and really compare them to the KarMMa trial. So tell us a little bit more about the process and how did you manage to do this and why you did this actually.
Yes, so thank you for having me. In terms of, I'm going to start backwards. So the reason why we did this is we were treating a lot of patients in the clinic that would not have been eligible. So I had a lot of patients with renal insufficiency, with very low creatinine clearance, or we had patients with poor performance status that was disease related, or we just had patients with a lot of myeloma in their marrow and cytopenias that, we wouldn't have been able to get on the trial. So I think the questions came up, and we had patients that had prior BCMA therapies as well, whether it be, antibody drug conjugates like belantamab or BCMA CAR Ts on clinical trial or bispecifics. But, there was a large population of our patients that, we weren't sure would benefit from Idecabtagene. I mean, we thought they might, but it was really worth looking at this effort. Certainly we had patients at Moffitt, but I didn't think that would be sufficient to really get an accurate outcome of how all patients do. So that's when we decided to build this CAR T consortium and reached out to some of our friends at different institutions who do take care of CAR T myeloma patients. And I must admit, I did have some guidance. So there is a similar lymphoma CAR T consortium that Mike Jane has led. And Roni, I'm sure, you've worked in the lymphoma space, but they had a very nice kind of guidance of how they build their consortium and a very nice spreadsheet. And we followed a similar model, making sure to look at myeloma specific variables. And certainly we adjusted along with Dr. Sarvasadana, Krina Patel at MD Anderson and Stanford, where we got together and identified and looked at all the variables and met with all of the respective members and made all of this happen. So it's been a very exciting and collaborative experience.
This is really fantastic, and you are telling the story so easily, so modestly, while we know very well that this is really a huge effort to build such a database and to bring 11 institutions together. So again, congratulations. So Roni, looking into these data, and actually what's quite amazing is that the numbers reproduce exactly, almost, up to the unit, what we had in the KarMMa trial. However, I'd like to get your thoughts here, and we'll go back to the issue of eligibility or non-eligibility. And by the way, guys, please don't hesitate to post your questions or comments, and I'd be more than happy to share them with Doris and Roni, because this is a live interactive activity. So we're broadcasting live. It's now almost 6:15 Central European time. So what did you think, Roni, for instance, about the rate of CRS and neurotoxicities reported there, and compared to what you know from the literature, because it looks like to me that in myeloma, these rates are relatively very low compared to what we have in lymphoma and ALL.
Thank you, Mohammed. Yeah, I think that what comes of this paper and others that have been published more recently is that really CRS and ICANS are a problem, but I feel like the main challenge in CAR T-cell therapy is actually shifting more into cytopenia management rather than managing CRS and ICANS, because we've learned a lot, right, along the way about how to intervene earlier and in a more aggressive way to treat CRS, sort of kill it while it's small, and also with neurotoxicity, we're less hesitant of giving steroids. We have, this is still not labeled, but we're using more anakinra, and again, the tocilizumab that is given often now in very early CRS. So I feel that the numbers we saw here are acceptable and definitely manageable, to the extent that, for some of these patients, you could think of even doing it as an outpatient. What I'm more concerned is about the cytopenias, and if we look at the grade 3 cytopenias in this cohort, I think it was around 60%, right? If we took a look at neutropenia and that also anemia and thrombocytopenia. So I'll kind of roll the ball back to Doris, perhaps, but ask her your sort of practice. How do you manage these cytopenias, or do you have any sort of early interventions to prevent them?
Yeah, Roni, so I couldn't agree with you more. I do think that the rates of CRS and neurologic toxicity, at least higher grade, have been, significantly lower than what you see in lymphoma. And we're pretty aggressive up front in terms of, using tocilizumab and steroids. But agreed, the biggest issue really or challenge has been long-term cytopenias of high-grade severity ranging 38 to 60% beyond day 30. And actually, Dr. Razan Moti presented, just to add something else, but she did present an ASTCT abstract where we saw 18% of patients still had grade 3 or higher cytopenias at 6 months. So that's quite a bit of a concern. Not only does it affect, their quality of life, how often they have to come to the clinic, transfusion management, use of TPO agonists, stem cell boost, etc. So I do think in terms of the way that we are managing them, certainly frequent monitoring of their CBCs, we are using more TPO mimetics. We saw about 15% use in this multi-center analysis. And also we are becoming a bit more aggressive with use of stem cell boost. Generally, if they don't have adequate or still persistent severe cytopenias between day 60 to 90 after a thorough workup, we are considering using more stem cell boost, which we saw about 5% in our original real world report. But certainly, as we presented at ASTCT, we need larger studies, and we need to kind of identify a model, like potentially the CAR hematotox, the data that was presented at ASH, to identify who are these high-risk patients and should we intervene sooner or earlier. So far, our experience is very limited with stem cell boost, but I know in the lymphoma world you have more experience, but it has been safe, effective, our patients are doing okay. And we're also very aggressive with anti-infective management or prophylaxis, including antivirals, antibacterials, and even PCP up to 6 months post-CAR-T.
So, by the way, you mentioned the very nice abstract last week by Dr. Razan Moti at TCT. I have to make a disclaimer. She's not my daughter. We have the same name, but people always, otherwise people will send me congratulations, email. She's not my daughter, but I know she is a brilliant young physician.
She is, I agree.
At Moffitt. And she has done some amazing
fantastic work.
So, Doris, you mentioned the issue of boost. Just to clarify, are we talking about patients who had like stem cells being frozen for whatever auto procedure in the past that we have used? Or are we talking about the concept of boost as we do in the allotransplant setting, where you would mobilize the donor again, sort out CD34 stem cells? Maybe if you can expand on this, but also, and I fully agree with both of you, that cytopenia is really the problem, capital letters, big problem. How should we anticipate this problem? Today, when you give CAR T cells to myeloma, especially if they were heavily pretreated, the bone marrow reserve is very poor, very low. I think we need to get ready to have a sort of a preemptive action by having these boosts or stem cells ready somewhere.
Yeah, no, I agree 100%. I'm glad you asked the question, because you're right, I wasn't very clear. So typically for myeloma, as we know, our patients in the first line setting will get a consolidative, our majority, as we saw here, 80+% will get a consolidative autologous stem cell transplant. So commonly what we do is we collect enough stem cells to have some cryopreserved. So essentially, when I speak about a stem cell boost, would be patients who have stem cells cryopreserved that were collected for a prior autologous stem cell transplant. These are not CD34 selected stem cells as we would do from a donor for an allogeneic patient with graft failure, et cetera. So as you note, I mean, this is really restricted to patients who have had cells collected for a prior autologous transplant. So there may be a situation where I have a patient who's never had a transplant, and I really have no options, and that's kind of a concern. In terms of, what are some predictive factors, that we've seen, or, something that potentially we could anticipate these patients will have high-grade cytopenias or may need some supportive care. So far, we had a very small paper in Blood Advances with a very small number, like 52 patients or so. And what we found is, patients who had high bone marrow burden, so like having more than 50% or so plasma cells in the bone marrow, or having grade 3 anemia prior to CAR T. These are some potential factors that could contribute to longer cytopenias, but like I said, that number is very small. We need a larger analysis, and like you said, we need to look at alkylator therapy, etc. And this was found in the BMS, actually predictive model for apheresis that they looked at ASCO, where yes, alkylator timing does make a difference. So certainly there's a lot that we need to look at, but I can't say that we have those answers quite yet, but hopefully we will.
Excellent. So Roni, if you have to anticipate a plan against cytopenia post-CAR, how would you proceed today? Is it about collecting stem cells to everybody? Is it about, I don't know, using systematically a cocktail of growth factors? We know sometimes we manage to salvage patient with a cocktail of EPO, TPO, GCSF. Historically, we used to have even GM-CSF and SCF. They're not available anymore. But what would be your advice, practical advice?
Thank you, Mohammed. I think that, we are sort of discussing a moving target, and that chance, I would actually like to refer to a paper you just published in Blood, I think today or a few days ago, by Tanya Jane and Fred Locke and others about management of cytopenias. I would say that unfortunately we don't have good data to guide us. I think we, our sort of practice has shifted in the sense that we give a GCSF at an earlier time point. We start TPO earlier, but it's really more on the physician discretion sort of level. And I would say that patients obviously getting into CAR T with more a heavy burden disease, perhaps even those who received more intensive bridging therapy. In these sort of patients, I would be more aggressive, started earlier, and also counsel the patient that this is going to be, it's not only about CRS and ICANS, right? And patients coming to CAR T cell therapy should acknowledge that and know that, and we should share that information with them. Okay,
excellent. Let's move now, Doris, to another important feature, I think, in this cohort, which has been excellent for me recently, because I was able, to say, well, okay, it can be done even while not fulfilling the karma usual criteria. So this is very important practical piece of information. Can you expand a little bit on those criteria that actually where patient can receive CAR T cells and in theory they were considered as contraindications to CAR T cells? So what are these key parameters that from a practical point of view the audience should be aware of?
Yeah, so that's a great point. So one of the main criteria that we've noticed, for example, if somebody has renal insufficiency, that, quite commonly myeloma patients will present with renal insufficiency. So if we feel that this is renal insufficiency related to myeloma, certainly CAR T does appear to benefit these patients. Another criteria that's that we've noticed potentially could assist more patients to get CAR T is performance status. So again, we have to clarify if this is poor performance status that is related to disease. So it's myeloma related. We do think that these patients could potentially benefit from CAR T cell therapy. And then the other thing that I mentioned before, if we have cytopenias related to the myeloma, certainly that's another consideration for these patients to receive CAR T.
So one question here, please. What about the issue, because you nicely mentioned kidney insufficiency, which of course most myeloma patients would have. They have, let's say, even those with sort of a normal kidney function have a fragile kidney function. How do we handle fludarabine as a lymphodepleting agent? Because we know in these patients, Renal insufficiency is a major barrier to the use of fludarabine. And on the other hand, fludarabine plus cyclophosphamide has been shown to be the backbone for lymphodepletion. Should we reduce the dose of fludarabine? Are there alternatives to fludarabine if for some reason we decide not to use it? Any advice to the community, a practical advice?
Yeah, so that's a great question. So in terms of patient with renal insufficiency, what we found, certainly in this multi-institutional analysis, there was differences in the way that fludarabine was dose reduced. This was per institutional protocol. There was not one protocol or one fits all type of thing. Here at Moffitt, we've actually treated multiple patients now on hemodialysis, and certainly fludarabine is dose reduced accordingly. Typically, we do about a 20% dose reduction in this patient population. We have not noticed, so in the large analysis that Dr. Sedana presented at ASTCT and ASH in patients with renal insufficiency, we did not notice truly a response or necessarily a response difference or a PFS difference. We just mostly noticed prolonged hospital stay was about 13 versus 9 days. And then we also noticed a higher rate of grade 3 cytopenias at day 30, but that really resolved by day 90. So overall, it appeared safe. And, we didn't have any significant worsening in renal function. Now, in terms of, alternative regimens, so I can say, and I can only give you a little preview because this work has been submitted to ASCO regarding cilta-cel, actually, not Idecabtagene, but in terms of alternatives, so there's been these different institutions that I'm presenting have used regimens such as most commonly bendamustine at about, I think we saw about 11. Anyway, in total, we had about 20% of our institutions that had used alternative lymphodepletion regimens. So 11% was about bendamustine. The rest of them were either Cytoxan, or here at Moffitt, we have done Cytoxan with cladribine. Just to give you a little preview, what we are seeing is inferior response rates with alternative lymphodepletion, but I can't go into any more detail than that. Now fludarabine has been restored to my knowledge, and we've been able to go back to fludarabine Cytoxan combination.
Thank you very much, and I appreciate that you shared some thoughts with us, and we're looking forward to see this work at the next ASCO meeting. But I do remember we had a journal club about the Marcello Pasquini blood paper, the real world CAR T-cell use in lymphoma, where this issue of bendamustine was brought into the scene, but actually in lymphoma it was slightly subtle because it was used as a bridge because it's a good treatment for lymphoma, so you could hit two birds with one stone. One question we have, and to both of you, if we have a patient who is under dialysis, how do we perform CAR T cells? I know that there are a couple of case reports in lymphoma, and actually, for me, my medical understanding is that if you are under dialysis, it's like you have an artificial kidney. So it's almost like you have a normal kidney.
Yeah,
so
I agree.
Business as usual. So what are your thoughts? Did you have any of these patients in your series?
Yeah, we did. So hopefully we're going to get that paper out soon as well. But we did have, like, our first patient, the dialysis patient, was treated here at Moffitt. And we have several lymphoma patients treated on dialysis, but basically we use the same type of regimen. Our first patient had to be altered a little bit because of volume issues, but I can say from the other patients we've treated, generally we do a Monday, Wednesday, Friday type of dialysis schedule, and we make sure that lymphodepletion is given about 12 hours apart from dialysis, and we commonly dose reduce any kind of fluids.
After dialysis, I guess.
Correct, after dialysis, correct. And then, as I mentioned, we typically dose reduce fludarabine at 20%. Now, I can also mention that our first patient had quite a few comorbidities as well. She did experience some volume overload problems. She did end up in the ICU, but within 30 days of CAR T, she was discharged from the hospital and had a pretty decent quality of life for a couple of months until she progressed. But she did achieve, like, her deepest response was a very good partial response. I can speak for the other patients we've treated on dialysis. We have not had fluid or volume overload issues because they've just looked better prior to coming to CAR-T than our patient number 1. But generally, it's been tolerated okay without any issues. And one of our patients was on peritoneal dialysis, and we've had to go a bit of back and forth to make sure it adequate clearance. But that Monday, Wednesday, Friday, and dose reduction and the 12-hour difference or post dialysis seems to be going okay for our patients here at Moffitt, at least.
Okay, excellent. Thank you very much. One question we have from Dr. Devanier for you, Roni, for instance. Do you have any clue about the most common reasons for CAR T-cell failures in myeloma? I know it's a $1 billion question because it can be related to the disease itself, to the microenvironment, to your construct, maybe all of them together. Any hints there? Any information from this paper about the predictive factors for failure or for success?
Yeah, I think when we're thinking about resistance, we're sort of thinking of a triangle, right? We have the product, we have the host, and we have the tumor, all sort of intertwined with one another. For the product, obviously, what we know from the pivotal trial that we need to go to a higher cell dose with Idecabtagene at least, and then we are still lacking some of the information that we have from lymphoma about the functional repertoire of the CAR T cells and expanding T cells in myeloma. It's still sort of early stage. From a host perspective, what we typically know, at least from the lymphoma literature, is that an inflammatory environment, high ferritin, high CRP, are associated with worse outcomes. I must say, I don't remember for the top of my head if the ferritin at some sort at some analysis here, but I don't think it has been certainly evaluated here, and it may have a role in myeloma. And then we go to the tumor, and the tumor we could think of several avenues there. One is really about antigen modulation, and there that's probably more common in myelomas than in lymphoma. We're talking about BCMA, so either BCMA loss or BCMA secretion, essentially, sort of as a decoy for the CAR T cell therapies. That's why we're also experimenting with gamma secretase inhibitors as part of the mechanism to prevent resistance. We can think about the tumor microenvironment, and an interesting question here would be, for instance, whether extramedullary disease made a difference. I don't remember it as a factor in that had a difference in the PFS analysis, but Doris, please feel free to correct me. Right, but
you're right, it didn't.
Yeah, but that I mean, the tumor microenvironment for sure could make a difference. And then the third sort of way I'm thinking about resistance here, and again, unfortunately, lack of data, it's more coming from the ALL and lymphoma field, is really about altered tumor signaling, right? Whether, for instance, a TP53 mutation, for instance, in lymphoma, we know they altered the tumor death receptor or extrinsic apoptotic pathway by which CAR T cell exerts cytotoxicity, right? We don't necessarily know that that's the case in myeloma. So I feel like specifically in myeloma, we have a lot to learn. And I'm sure hopefully there will be follow-up on these studies, especially on looking on the biopsies before and after CAR T cell therapies, trying to understand what are the molecular drivers of resistance, whether it's inherent or acquired.
Doris, any comment on this?
I'd say that Roni has really covered it pretty well, but I very much agree, an inflammatory state, baseline ferritin, although it wasn't shown in this original paper, Roni, to go back to your comment, we have seen that it is one of the predictors, especially for earlier relapse or progression. certainly, like you mentioned, low viability, insufficient, lymphocyte count, pre-treatment because of alkylator exposure and whatnot. But yeah, I agree with what he said.
So one question to you, Doris, from Dr. Salihoglu about whether you had cases of patients with CNS involvement and whether CNS involvement in general would influence the issue of neurotoxicity and ICANS.
Yeah, so that's an excellent question, actually. We did have one patient who had CNS involvement. This patient was treated with intrathecal chemotherapy, and they did end up clearing the myeloma pre-CAR-T in the CNS. This was actually the only patient in our cohort that ended up dying of neurologic toxicity. And this was kind of presented more of like an ascending paralysis, akin to Guillain-Barré, but the CNS was negative for myeloma. So certainly, I mean, this is a one patient case, so difficult to make any conclusions, but this was the patient that did die of neurologic toxicity, and an atypical one at it. So certainly it's a consideration in the future to be very careful in this patient population.
Okay, fantastic. So now my last question to you, Roni, and actually to you also, Doris. You've been working a lot, Roni, on CAR T cells and analyzing larger cohorts. You are highly skilled in data mining, the role of artificial intelligence. What would be your advice today to optimize our understanding of these novel therapies using real-world evidence and data that I think, based on this work, should become almost mandatory, I would say, because we see now the drugs being approved very quickly based on, and that's good news, it's not a criticism, based on small single-arm trials, but then you have to play with the drug and start to understand and know how to use it, how to optimize its use. So what is your general advice before I ask Doris about what are the next steps?
Well, again, we're going back to our starting point that this is a testament of the importance of real-world data and collaboration. I think in order to drive the field forward in the sense of understanding why patients fail, or why treatment fail, I should say. It's really about permissive data.
You're absolutely right to mention this. It's always the treatment that fails the patient, not the other way around. We get it wrong frequently.
Exactly. So I think that we should really stress the importance of permissive data collection. Sometimes, as an illustration, right, sometimes basic laboratory covariates, right, like ferritin, CRP, that we collect as standard features, right, the standard clinical care, can actually tell us a lot about resistance. That's how we learned about inflammation as a driver of resistance, essentially. And now there are interventions guided by inflammation, essentially, to reduce the inflammation burden in these patients. So I think one issue is just take off the brakes, collect everything you can, and connect the system to the EMR, permissive data collection. Then, obviously, it's about biosample collection. Again, trying to be very permissive about what you collect everything. Everything could be valuable here. I mean, we need to learn every blood sample, every tumor sample. And this sounds easy, but actually, this is one of the most challenging stages. So making a biorepository is a huge effort. And then I think the third arm there, or the third leg, is really about technology and how to mine that data, whether it's small or large. And I come a bit from the field of AI. And sometimes, when you have a very high dimensional data set, meaning that you have more features than patients or samples, then you need to sort of think about what are the high throughput techniques that will help you yield the most of your data. But I think that collaboration that you're presenting is really a step in the right direction.
Thank you, Roni. Doris, so now, very nice, beautiful JCO paper. What are the next steps? I mean, you already alluded to some work submitted to ASCO. You alluded to some subset analysis, dialysis, maybe other stories. How are you going to take this topic further and further, I would say, inform the community about how to refine and optimize the use of CAR T cells in myeloma in general, not specifically Idecabtagene, but also other different constructs. We know that cilta-cel is approved, and there are many other exciting constructs being developed.
Yeah, so it's a great question. Going back to what Roni was saying a little bit, and then I'll go back to your question. In terms of the inflammatory microenvironment, we did have a small data set at ASTCT looking at just this very question. So we looked at certain cytokines, including interleukin-6 and baseline ferritin, CRP, and essentially what we found is, yes, patients with elevated baseline ferritin, elevated IL-6 at baseline did have increased risk for higher grade toxicity, specifically CRS, and a trend for neurologic toxicity, and an inferior PFS overall when looking at optimal cut points. So certainly I do think that's very important. And going back to your biorepository comment, that's also something that we are very much invested and committed to here at Moffitt and across some of the institutions that we're collaborating with. We're currently working on multiple projects, including some with the University of Miami, Stanford, MD Anderson, looking at some of these specific translational questions. So what can we do to mitigate morbidity and mortality and reduce not only toxicity, but also improve treatment outcomes and PFS in this patient population who we deem to be high risk. In terms of some upcoming projects, so in addition to these collaborative ventures, whether it be real world data or some translational work, we're also, hopefully you guys will be seeing soon some work on quality of life on these CAR T patients as well, which should be very exciting and should be submitted soon actually. At ASCO, you'll see a preliminary view of cilta-cel outcomes in the real world setting with a cohort of about 139 patients, 177 leukapheresis, so pretty large group. And then in the future, I think not necessarily applying to all CAR Ts, but potentially for lymphoma as well, this could be important. But in the myeloma setting, one thing that we've noticed that's important or lacking is the sequencing of BCMA targets, because really all we have right now is, BCMA CAR T, BCMA bispecifics. Hopefully in the future we'll have more because there's many clinical trials like GPRC5D, but looking at all of these patients, Idecabtagene, cilta-cel, teclistamab, and we're also looking at teclistamab and the first wave of teclistamab, the post-CAR T treated. This is also another very important question, the sequencing of bispecifics and CAR Ts and how would our patients benefit best. So we have a lot of work cut out for us, and it's all very exciting.
Well, thank you very much. This is really a beautiful conclusion, and I fully agree with you. It's just the beginning of this immunotherapy revolution in hematology, because obviously it's not only about CAR T cells, but we're also talking about all of the other immune therapy tools like the T cell engagers, the bispecifics. It's also about the innate immunity engagers, but there are also other CARs, the NK CARs, the gamma delta CARs, and many, many others. So with this, I'd like to conclude this journal club. It was a lovely and fascinating discussion with Dr. Roni Shouval and Dr. Doris Hansen. Again, congratulations for this JCO paper. I do apologize. We were not able to take all the questions, but I'm sure you can reach out to our panelists by email, and they would be more than happy to be in contact with you. So wherever you are, I hope you have enjoyed this journal club brought to you by the International Academy for Clinical Hematology. And thank you for being loyal to the ICH and for your kind comments. And I cannot reply personally to each person thanking us for the great discussion and activities. But we have launched a couple of days ago a survey about how would you assess the different ICH activities. So it's a good opportunity maybe to take this less than 5 minute survey, guys, and answer a few questions to help us how to improve these activities. Our next journal club is in around 15 days, but in the meantime, you will see we have a lot of other activities. Will be next week, I think, a beautiful webinar about the revolution that is also ongoing in classical hematology, and this is going to be about the management of hemophilia and the different gene therapies. Absolutely not my field, but you will have really top expert, Professor Macris, handling this topic. And I've just been told by our engineer that there will be a link to the survey at the end of this broadcast. Thank you very much. Please stay safe and keep well. Good night, good evening, good afternoon, or have a good day.